move, move to the next talk, that is OCT interpretations and artifacts. OCTA was first introduced in 2014. It's a new armamentarium in retinal imaging, fast and non-invasive, dye-free angiography with faster acquisition. Prior to OCTA, FA and ICG were the mainstay and the modalities for retinovascular visualization. FA and ICG generated two-dimensional in-fast view of the retinal vasculature. OCTA allows individual visualization of retinal capillary plexus. OCTA in vivo visualization of the retinal microvascular in a depth resolution fashion. Uh, if you look at the OCT image, it gives a cross-sectional image. Like if you cut a cake like this, you will see multiple layers of the cake. Similarly, OCT B scan gives a cross-sectional image of the retina. But if you go on to the Octa images, this gives you an in-fast image. And like you cut the cake in a horizontal fashion, then you get multiple slices. And this is what an Octa does. Uh, Important thing in Octa is segmentation. So you see this line moving here, this line, and if you see this line moves, and if it when it comes to the level of RP, you can see the lesion. So it's very important whenever you are interpreting an octa image, you have to look these lines where they are placed and in concurrence with your retinal pathology. Because if these lines are made up and up, below, then your diagnosis with octa will go wrong. Uh, this is a small video showing how OCT angio is done. And since I have a Zeiss Angioplex 6000, so it's a non-invasive dye-free with single scan. Motion of red blood cells is detected by sequential OCTs. Based on the properties of light reflected from red blood cells, motion is detected and vessels with blood flow is detected. It has a fast track system, so motion artifacts are decreased in this system. And patient blinks, it stops, and once the patient starts fixing again, it again starts tracking the eye. It is powered by OMAG algorithms, which takes care of the amplitude and phase from the OCT in single data. You can see multiple layers. This is a superficial layer, this is the deep retina, and this is the avascular layer, and you have the choroid and the choriocapillary layers. There is a color coding. Red is for the superficial, deep retina is green, and avascular retina is blue. So if you see a compact image, there are preset modalities here. You can see retina, superficial layer, deep layer. These are angioplex pictures, and these are structural or deep layer, and then you have an B scan pictures. And these red dots what we see is an flow overlay. So we have two machines. One is spectral domain versus swept source OCT, and as Ritesh has already mentioned, uh, swept source is faster and covers a greater scanning area. Choroid can be scanned easily in swept source, but resolution is higher in spectral domain OCT based Octa systems. The problem with swept source OCT is the cost is double. Whenever you are interpreting an octa image, there are three images here. One is an NFOS image. This we call as an angiographic image. Then you have an structural NFOS intensity image for the selected slab. And you have an corresponding B scan image. So whenever you are interpreting an octa image, all the three images has to be taken into consideration before interpreting any disease pathology. Uh, the area of a scan is determined. Then look at the NFAS image. Look at the segmentation line. These red lines are segmentation line. Look at the B scan with flow overlay. This red dots and green dots, what you are seeing, shows the vascular flow in the particular area in the vessels. And then you look at the intensity image, or what we call as in structural images. The first step is to interpret, to ensure which area of the retina you want to scan. Depending on the type of lesion, you can choose the block. If it is a CNV, you can choose a 3 into 3 millimeters, or a larger macular lesion, 6 into 6 millimeters. Diabetics, you can, because you need more area for capillary non-perfusion, you can either go in for 8 into 8 montage or 12 into 12 slab. This is what you see. This is 6 into 6 slab. This is good for macular area where you want to see a magnified image. If you want to look at the peripheral image, then you have to go for an 8 into 8 montage. And since montage, what happens, you have to take 5 pictures at a time. So the acquisition time increases, so you can do 12 into 2 a 12 scan, which will give area similar to 8 into 8 montage. And if you have like Plixelite 12 into 12 montage, then you can get 16 into 16 scan, which covers till the equator. There are various preset features shown in the report here, which shows a superficial layer, deep layer, avascular zone, choriocapillaries, and each of the layers I'll be discussing here. The superficial retinal slab extends from internal limiting membrane, ganglion cell layer, and inner plexiform layer. Uh, Captures the superficial capillary plexus, part of the radial peripapillary and capillary plexus. This slab is important in retinal vascular disease where dropout or malformation of microvascular circulation is seen. Like in this patient, whenever you want to see a foveal avascular zone, then look at the superficial slab. You can see a regular foveal avascular zone. And then if you see in this patient, you will see areas of capillary dropout and macular ischemia. Deep retinal slabs extends from inner nuclear layer out to intermediate deep capillary plexus. OCTA is the only available tool which can detect deep retinal slabs or deep capillary plexus. Deep capillary plexus cannot be taken or distinguished on fluorescein angiographic picture. And this is you can see this slab here. If you click on this, you will get deep capillary plexus, and the line segmentation lines comes below the in the middle of the retina. The avascular zone extends from outer plexiform layer, the outer nuclear layer, and this slab is avascular in healthy individuals. Any vasculature in this slab signifies pathology, and these pathologies can be CNVMs or neovascular abnormality. Coming to the choriocapillary slab, this is the choriocapillary slab is defined as 20 microns below the retinal pigment epithelium. Much like the avascular slab, the choriocapillary slab should be evaluated in AMD and other pathologies associated with MNB formation. Choriocapillary slab, you won't see the vessel, you will see voxels in this. And in this patient, what you can see here is a CNV, uh, and there is also one slab called sub RP slab. If you see the sub RP slab here, you can see it automatically takes care of the motion artifacts. So it automatically follows the line of the pigment epithelial detachment. And if you see here in sub RP slab, I can detect an PCV or an polyp here uh, in an pigment epithelial detachment. ORCC slab is a combination of outer retinal and choriocapillary slab. It was first described by Rosenfield. The slab spans from the outer plexiform layer, the outer nuclear layer, and the choriocapillaries, and is best in case of type 1, type 2, and type 3 CNV. And this is one of the patient of juxtafoveal telangiectasia. You can see an atrophy here with the simultaneous CNV. Another patient undergone, if you see this slab, you can see a CNV, and SRF here. So all three images has to be interpreted to come to an conclusion. Choroidal slab displays a 50 micron slice posterior to the choriocapillaries. Differences in wavelength and light source lead to variable detection of choroidal vasculature. This is one of the patient. You can see this segmentation line. This is in the choroid, and you can see a large dilated vessels, which suggests that this patient is of pachychoroid disease. Segmentation line, we have talked before also. Preset slabs in Octa devices are generated by automated segmentation. And because of many times, because of this pigment epithelial detachments, you are not able to detect where the lesion is. So you can see here, if you see, this is, we are scanning the superficial, but I have done a manual segmentation. I have brought down, you have to roll click here and roll your mouse, and this segmentation line comes here. And if you see in this patient, you can see an BVNs, which is suggestive that this is a patient of a polypoidal choroidal vasculopathy. Within edge of the PED, you can see an branching vascular network. uh, B scan overlay is basically, if you see this red dots and yellow dots, this shows what is the flow of the blood at a particular area. So whenever you have to see whether it's an artifact or actually you have to, what is the flow into it, what you have to do, you have to bring this line in the area where the lesion is. Then if once you bring this line, you will get a simultaneous B scan pictures, and these red dots will show that there is an high perfusion in this area, suggestive these are not artifacts. Actually, these are abnormal vessels which you have to treat over a period of time. In many high, then the third image what you see here is an structural image. And if you see here, this is a patient of a diabetes, but on Octa pictures we can see areas of capillary non-perfusion, but we cannot see an NVD. But in structural image, what you can see, there is an NVD here and there is a fibrovascular proliferation. Maybe the blood flow is not there, so you are not getting a flow in this area, or you cannot detect an abnormal vessel on the disc. Meaning thereby, one image in Octa will not give you a definitive diagnosis. You have to correlate all these three images to come to an final conclusion. Uh, Octa also helps us to compare picture. This is one patient. You can see the signal strength is good and almost the same. Uh, we have given anti-VEGF. This patient was QSIN for a period of 4 to 6 months. When came, there is an enlargement of an CNV or a progression of a CNV. This indicates yes, you have to re-inject in this patient. Coming to the artifacts, there are various artifacts: signal strength, motion artifact, projection artifacts, and segmentation artifacts. Uh, Whenever you are interpreting an Octa image, you always look at the signal strength, which is given here. And you can see there is a loss of capillary perfusion in this area, and the B scan images are not clear. This patient had an posterior subcapsular cataract, and because of this subcapsular cataract, the acquisition is not good. So this is very important to prevent any kind of a misdiagnosis, because if you see this picture, you will see say ki there is an enlargement of FAZ, but actually these pictures, these are artifact because of the posterior subcapsular cataract. Uh, Motion artifact, if you see this lines here on the structural images, this tells us that the patient fixation was not good whenever when the image acquisition was taking. And motion artifacts are taken care by two softwares. One is an eye tracking device and software motion correction devices. And because of this tracking, most of the machines now have a tracking device. So motion artifacts are becoming lesser and lesser. uh, the moment you do a smaller slab, then the motion artifacts are less. Larger slabs requires more time and more time for fixation. So if you go for a 12 into 12 slab like what you see here, the chances of getting motion artifacts are higher as compared to taking a smaller slab. Uh, Shadowing, this is one of the patient you can see is this patient has an pre-retinal hemorrhage plus and subretinal hemorrhage. And if you see this picture, because of the pre-retinal hemorrhage, there is an shadowing to the underlying tissue. Uh, if you see this here, this lesion here, the vessels are dilated and you can see the flow is pretty high. So this is one of the patient we could diagnose on OCTA as a case of retinal artery macroaneurysm. Uh, Projection artifacts, you can take care of the projection artifacts by manual segmentation. Like in this patient, I did a manual segmentation and you can see a notch PD, which is suggestive of an fibrovascular disease process. And at the edge of the notch PD, you can see a BVN. And we do an sub RP scan where the motion projection artifacts are taken care. And in this patient, you can see an polyp here, one single polyp. And this is one of the rare cases where I have been able to diagnose a polyp in cases of NPCV. There are projection artifact removal softwares which are available in the machine. I won't go into the detail because of the time constraints. Slab subtraction, voxel by voxel, and three-dimensional power algorithms are available to diagnose this disease. Projection, when interpreting octa images, the easiest way is to detect projection artifact is to compare in-fast flow with the corresponding B scan. Like what I have shown here, the flow is good here. That means there is no artifact in this image. Segmentation artifacts we have already discussed. So to conclude, all three images enforce octa images with structural OCT with B-scan. Flow overlay should be assessed for the correct diagnosis. In doubt, always sit on the machine for correct segmentation and B-scan overlays. It is evolving technology with lot of things to learn. Thank you very much for your kind attention.